Hello, this is Dr. Mark Lebwohl. I'm the Waldman Chair of Dermatology at the Icahn School of Medicine at Mount Sinai in New York. I will be discussing Secukinumab retreatment shows rapid recapture of treatment response, an analysis of a phase 3 extension trial in psoriasis, presented by Dr. Blauvelt and colleagues at the American Academy of Dermatology annual meeting that took place in Orlando from March 3rd to March 7th, 2017. To summarize this poster, Secukinumab retreatment restored efficacy within 16 weeks in patients with psoriasis after being withdrawn from therapy. The safety profile of Secukinumab was consistent with previous reports. The reason this study is important is that treatment interruption is a common occurrence in patients with psoriasis and has been shown to often lead to reduced efficacy upon retreatment. The results of this study showing recapture of treatment response with Secukinumab retreatment indicates Secukinumab is a good option in this challenging population. Here's how the study was designed. This analysis reports results from the extension phase of the erasure and fixture phase 3 studies. In the erasure and fixture studies, patients were randomized equally to Secukinumab 150 or 300 milligrams or placebo. There was a fourth arm in the fixture study in which patients received etanercept 50 milligrams per week. Treatment was administered at baseline and at weeks 1, 2, 3, and 4, and then every 4 weeks. At week 12, placebo patients who did not achieve a PASI 75 response were randomized to Secukinumab 150 milligrams or 300 milligrams. Patients who had PASI 75 responses at week 52 were randomized in the extension study 2-to-1 to continue on the same dose of Secukinumab or to receive placebo every 4 weeks. Patients who relapsed in the placebo arms of the two studies were retreated with Secukinumab at week 0, 1, 2, 3, and 4, and then every 4 weeks. Relapse was defined as a loss of 50% of the maximum PASI gain compared with baseline in the erasure and fixture studies. This poster is an analysis of patients who had a good response to Secukinumab, and by that we mean that they were required to have a PASI 75 response, and then were switched to placebo to create active treatment withdrawal, and were then restarted on Secukinumab once they had relapsed. Key findings were as follows. 181 patients were included in this treatment response, then treatment withdrawal, then treatment restart group. 136 of the 181 patients, or 75.1%, relapsed upon treatment withdrawal at a median of 28 weeks and were subsequently treated with Secukinumab. Recall that these patients had a PASI 75 score at 52 weeks, so all of them with PASI 75. In these 136 patients, 93.8% achieved a PASI 75 response at 16 weeks following initiation of retreatment with Secukinumab, which is an excellent recapture rate. In the patients who had a PASI 90 at 52 weeks, 95.8% had a PASI 75 at 16 weeks following initiation of retreatment, and 78.8% had a PASI 90. 67.3% had a PASI 100 at 16 weeks following initiation of retreatment. Patients, the mean exposure to Secukinumab per patient was 202.2 days. Adverse events were consistent with previous studies and presented no unexpected safety findings. Now, I will say that one of the striking results of this trial was that 25% of patients actually never relapsed. So they continued in the trial long-term and did not relapse. Long remissions in 25% of patients. Literally, the nature of the disease appeared to have been modified by treatment with Secukinumab. The median time to relapse following the withdrawal of Secukinumab was 28 weeks in those who did relapse.